Hey guys, welcome back to the Foam Frat podcast. I'm joined with a coworker, Chris Carlstrom. He's a flight nurse at Lifelink 3, and he also has experience working in a ketamine infusion clinic. And we've had some really interesting chats while we've been on shift together. Chris, welcome to the podcast. How you doing, man?
Thanks. I'm doing great. Thanks for having me on.
Yeah, absolutely. So I was picking your brain because I've been redoing the analgesia pain management section and also just some classes that I've done on ketamine. And you are working in a clinic where, on a day to day basis, not that you're working every day, but your typical thing that you're seeing when you go in is people getting ketamine. And I'm sure everybody responds a little bit differently. And it was very eye opening as you were talking about some of your experiences. So I thought we could start off with just talking about what did you learn working at the clinic that you didn't really know as a nurse or as a because you worked as an EMT as well, right? You didn't work as a paramedic.
Correct. Yeah, I worked as an EMT for 6 years as well.
Yeah, and then you went and you worked as a nurse and you were in like ED, ICU. So your opinion of ketamine before actually going to and seeing how it was used in a ketamine clinic, what was different about that? What were some of the things that were eye opening?
Yeah. So my first knowledge of ketamine came from the emergency medicine setting. Starting when I was an EMT, and then moving into my time in the ER and a little bit in the ICU. It's not certainly not used as commonly in the ICU as it is in the ER and in emergency settings, but learning about it from that perspective, it's taught as a sedative. You hear that it can be used to sedate, behaviorally agitated patients or to intubate patients and maintain sedation for these patients. And there's really not a lot of discussion about the variety of perceptual effects that it can have on patients. And so then moving into my experience in the psychiatry realm, where ketamine is now more commonly starting to be used for treatment of depression, anxiety, PTSD, and other mental health diagnoses. There's a lot more discussion about the effects on perception, you know, and as with many drugs that relate to the central nervous system and to augmentation of perception and have these psychoactive qualities, there's not a lot of definitive consensus on how these drugs work, and how they're exactly going to affect each patient's unique psychology. So those are the considerations that are looked at much more closely from the perspective of using ketamine to treat psychiatric illnesses. um, so coming into that role, that was a big, I'd kind of learned about some of this stuff preceding that role too, just out of my own interest, and that's part of what led
Mhm.
me to it. But in that setting, I was really able to, in a controlled way, watch the way that patients respond to ketamine. you know it, and that's the whole purpose. They're there. It's not being used in the context of a complex critical care situation. So yeah, there's
Yeah.
I could talk about this for a long time, but kind of the gist of my exposure, that's the difference in perspective through which ketamine is seen in emergency medicine and in psychiatry, at least in my experience.
Would you say that the patients that you have are partially dissociated, or are they fully? What is the target for that?
Yeah. So, I mean, there's, of course, a range of responses that patients have depending on their dose. Some, remember their experience afterwards, some don't. But I mean, just kind of to speak to the broad question, yeah, we are in this environment that is designed to produce an experience that's not distressing. So prior to their first dosing session, they meet with a mental health provider and have this discussion about what is ketamine, what is it going to do, what are things that I can anticipate. So there's this, and a lot of patients also actually will do their own research, and learn on the internet or through social media or whatever avenue about what to expect. So there's this huge difference between giving ketamine to somebody in a critical situation that's already traumatized, from whatever's happened to them, um, versus the setting where they've prepared for this. They have some awareness of what's going to happen. It's comfortable. There's nice pictures on the wall. It's all of that. And I think that definitely drives the experience in a very different direction than we'll see in emergent settings.
Do you ever see somebody and you immediately know, oh, they're going to have a bad experience with ketamine? Like maybe there's just something that they or the way they present or a certain disposition where you can tell right away that this person's going to have a bad experience with it.
Yeah, it's not incredibly predictable. And I mean, the other thing to take note of is that just because they have a distressing experience in the midst of the session doesn't mean it's not going to have the intended effect in the long run. And
Yeah.
sometimes patients look back on a day that was really distressing for them and say, that was like the days after that were really good. And like I got something out of that. So,
Kind of
sometimes
like
those areas that
EMDR
we
too.
yeah, yeah. Those
Yeah.
areas we try to avoid when we use ketamine and for its applications in critical care are effects, perceptual effects that are actually, you know, potentially beneficial to patients who are trying to alleviate symptoms of depression and anxiety through using ketamine. So,
Yeah, absolutely. So, in your let's take off the ketamine infusion clinic hat and let's say
mhm,
you're working on the helicopter and you got a patient that you want to treat their pain and you are going to give them the, zero point 0.1 to zero point 0.2 milligram per kilo range. Say the 100 kilos, you're going to give them like 20 milligrams. Um, we've all seen patients respond very well to that, and then patients who just do not tolerate that at all. And so, right now in the world where ketamine is on back order pretty much everywhere,
mhm.
I don't think it makes sense to take ketamine out, a 500 milligram vial for 20 milligrams or 25 milligrams of it. But are there specific patients that you're more likely to use ketamine for the pain management side as opposed to something like fentanyl?
Yeah, I mean, I think the best way to prevent the adverse effects from ketamine at that dosing range is to educate the patient, which it depends on the context that you're working. But, in flight, it's
Right.
kind of hard to be able to have a dialogue, just because of the noise and whatnot. On the ground, maybe you can, if you have a 20, 30, 40-minute transport time, maybe you take 5 minutes. And you're like, okay, we're going to try this drug. You seem to, continue having pain here that's refractory to fentanyl or whatever you're using. And then, once you can provide kind of some information to them about what's going on, if they can receive that and, calmly interact with you, I imagine that would be a really effective or at least a better way to administer it than just saying, all right, we're going to try a new med. And, all of a sudden they may be
Yeah.
experiencing a perceptual state that's completely foreign to them in the midst of this, situation that's already a pretty stark deviation from what they expected out of their day. So that's it, patients that I can have that dialogue with. I think I would feel better about giving ketamine to than just throwing it at somebody who's maybe just kind of anxious and out of control. In that setting, maybe you try to adjunct or use a benzo as an adjunct to your pain management versus like saying, okay, fentanyl didn't work, let's do ketamine. Of course,
Yeah.
there's artistry to this, but that's kind of my
Right.
my thought.
Do you guys ever have to use benzo as like a rescue if somebody gets like in a bad spot and in the lab in the clinic?
Yeah, so we don't even have it actually we don't have a
Oh, really?
benzo at the clinic to give. So, I mean, if it was to the point where like the patient was behaviorally dangerous, it would need to be a call for EMS. Um, in my experience here, actually, we've never called an ambulance during one of my shifts. I know it's happened other times, but it's mostly a medical concern. Like patients, some of these patients have comorbidities and um, I can't even think of hearing a story about a patient that needed to receive a sedative because of a behavioral issue arising during ketamine. So the intervention at that point is um, just talking with the patient and
I was gonna say
addressing
more
whatever
ketamine.
is distressing. More ketamine, yeah. Well, sometimes I mean sometimes it's pausing the ketamine, but I mean again in my work there, I've always been able to just sit with a patient and either just be a presence or just provide reassurance. It's, I'm not a psychotherapist. I'm not guiding them in any
Right.
direction, but it's just like, you're safe. You are, you're in a setting where we can take care of you and you're not going to be in danger. And oftentimes that is enough to just redirect a patient and make them feel comfortable with whatever distressing perception they're experiencing.
That's awesome, man. Well, I can't thank you enough
Yeah.
for coming on and let me ask you a few questions. Before we close out, if you had to, you were standing in front of a room of new paramedics or new nurses, and you had to give them one piece of advice when it comes to administering ketamine, what would you say? What would be your elevator pitch when they go, "Hey, there's this drug I hear everybody's using called ketamine." What would be your response to that?
Yeah. I mean, I think it's very possible that in your education, you won't hear about the kinds of perceptual effects that ketamine can have on patients. And coming from a perspective where I've, been around probably hundreds, maybe thousands of patients who have received ketamine, they will report that they've experienced anything from feeling like they've died to feeling like they've met God to feeling like they're in Minecraft. I've heard that they feel like they're in the multiverse, like fighting Doctor Strange. So, I mean, this is a drug that it has the label of being a dissociative anesthetic, or dissociative sedative, but it has psychedelic properties. It has hallucinogenic properties. And so, for somebody who's never traversed that kind of perceptual state in their life, giving this in a critical situation can put them there. I remember having a lady who was in a motorcycle accident, and we did some conscious sedation with ketamine, and she came out of it just like feeling like she met God, and having had this unbelievable, literally for most people who haven't experienced that, it's like this unbelievable description of this state of perception that they had just traversed in the middle of one of the most traumatic accidents of their life. So just know that
Wow.
that is the weight of what can happen when you administer ketamine. And I did not know that for many years of my career, until I kind of heard some anecdotes, and then ultimately came to be administering ketamine in a setting of psychiatry clinic. So.
Yeah, you imagine, dude, like you if you go into like and you sit in a clinic and you have maybe an experience, but when you get in an accident and like you think you're going to die, everybody always thinks they're gonna die when they get in an accident. Oh my God, am
Mhm.
I gonna die? And then you give them something that makes them feel like they just met God.
Right.
Like I can't imagine. Like that's probably why you don't see patients in the ICU on ketamine drips. I
Mhm.
mean, like they want to, I don't want to say depressive, but you see propofol, Precedex, but you don't see people typically on a ketamine drip in the ICU for an extended period of time. And I don't know if that's because of some of those perceptual effects. How long could you possibly live in a dream where you're fighting Doctor Strange? Like eventually, you're going to have to like come one way or the other with that. And who knows, maybe we'll learn something eventually, or like you said, maybe some of those effects that they experience actually end up helping them with trauma later because it's not suppressing the trauma at that time. We have no idea, but it is very interesting. And it's interesting to hear your perception or your experience with that in the lab. It'd be cool if you could have paramedics just go shadow in those clinics to see how slow they push it. How
Mhm.
long this amount of is going over. I remember some of the doses you were telling me. I mean, didn't you tell me like 1 to 2 milligrams per kilo? What's the highest dose you've seen in the infusion
Gosh.
clinic?
I mean, I know for sure like up to 180 I've seen. And um, again, either as an IM injection or IV over 40 minutes, which when you do the math on that, if you were to think of like the hourly administration rate, it almost, I mean, it pretty much does get into the dosing range that we use to keep intubated patients sedated. And I mean, when I think
Yeah.
about that, I'm like, what are these patients experiencing? You know, and we don't ever get to
Hmm.
talk to them later. And, and I mean, there's not a lot of case reports that I've been able to find of patients talking about having some crazy psychological experience after they were sedated with ketamine you know, for critical care reasons, like being intubated. But I wonder that, and I think there's a lot of research to be done. Recently, there's been some research looking at ketamine being used for induction during surgery in depressed patients, and then looking at their postoperative depression in comparison to, a control group. And there's been some findings there that show that it helps reduce postoperative depression. So there's a lot of potential to use ketamine in new and different ways. It's, kind of back to the topic of using it in the ICU, or I guess not using it as frequently in the ICU. it is kind of a notoriously unreliable drug, both hemodynamically in terms of respiratory depression, in terms of the psychological effects. So we could have a whole separate discussion on how it's going to affect blood pressure. Is it going to cause a patient to have problematic respiratory depression? So it is, in that sense, it's kind of a tricky drug to use at times.
Oh, no, absolutely. All right, before we close it out, one last question. So you intubate somebody and you used RSI as your induction med. How well do you believe in the analgesic properties of that? Are you saying, nah, I don't need fentanyl? Ketamine has analgesic properties. Or are you still probably giving fentanyl with it?
This is kind of again, it's part of the artistry. If I have a patient who's exhibiting signs of pain, maybe they're tearing, maybe they're hypertensive and tachycardic, and there's not another reason for that to be the case, I'll augment it with fentanyl. I've certainly done that. There have been other times where there's not really other indicators of pain, and at that point, I'll assess that the analgesic properties of ketamine are sufficient for that patient's needs. Um, yeah, I mean, it's very
It's
case
hard
by
because you get a
case.
baseline
So
elevation in heart rate with ketamine, like,
right,
you give ketamine, you're
right,
gonna get a little baseline, so it's hard to tell sometimes, like, what is it? I like, normally, I typically will still give fentanyl on top of
yeah,
it, like,
yeah,
I'm sure it does have, analgesic properties, and obviously
yeah,
you're controlling it's working on not allowing that glutamate to come over to the other side of the cleft. But I do
hmm,
feel like sometimes I'm like, I don't know how much this actually is helping with pain. And that's probably because I'm seeing the heart rate go up because of the ketamine. But I was just curious. I've talked to people
right,
on both sides of the fence with that.
yeah, yeah. No, I mean, it's definitely a sympathomimetic. It blocks alpha two receptors, so you get that sympathetic surge in a healthy patient. Patients with some type of myocardial um, disease or issue will probably have hemodynamic deterioration, but everybody
Right.
else, a normal, healthy, 30-year-old trauma patient, their heart rate's going to go up and their blood pressure is going to go up. So that does make it tricky to use those measures of pain. And also the mechanism of pain management, or I guess analgesia with ketamine, is not well understood. It's kind of thought to maybe be part of the dissociation where patients just don't care about the pain as much. Um, you know, or it could be related to kind of opioid receptor agonism that is known to happen with ketamine too. It's not well defined. So augmenting with an opioid, I don't think is ever the wrong answer.
Awesome, man. Well, Chris, thanks so much, buddy. I appreciate you coming on. And if we have any follow-up questions, maybe we can have you back on to answer those.
Yeah, absolutely. Sounds great. Thanks for having me. This is something I'm passionate about. So I enjoy sharing what I know.
Awesome, man. Thanks, buddy.